this polyp, obviously everybody can see, has already been resected. So we want to focus a little bit, not on the resection itself, but on the defect interpretation. So is there any points you would like to specifically address, or you think you have a difficult with, that you would maybe want to focus on these points?
Mm-hmm. So firstly, to assess the defect, the technique of put it on the water and assess it with knee focus, that's something I can do comfortably. But what I struggle with is sometimes in a post-TMR defect, sometimes you see a vessel that might be transected or not, when to treat, when not to treat. Okay. And sometimes also doubt a little bit about maybe residual, maybe just some cold snap to when to do cast of it, when not to do that. Yeah. So those things, yeah.
Okay.
Yeah, and if you're not going to clip, then you need to avoid that. By the end of this, there was a lot of diathermy injury to this defect. So if we just flip right back to the start and look at Lynn's beautiful defect, and I agree with John, it was absolutely beautiful. I was a bit annoyed with her that she hadn't let me do it, but in the end, I cannot fault it. It was excellent. If we just go back a bit more, yeah, look at that. I mean, you know, don't get things that look much better than that. This down here may be something, but okay, we looked at it. But then when you go on and you see at the end, now compare that in your mind to what we had after all that diathermy that we applied here. If they had said to me, well, I'm not going to clip that because I don't think the risk of bleeding, or the patient is, you know, not at a risk of bleeding, maybe they're young, no anticoagulants or whatever, I would have said, well, look at the amount of diathermy injury you have to the muscle here. You absolutely must clip it for that. And the final technical point, Xander, is that my tip control score was still not as good as I expect from you. It was still 73. And the reason why it's 73 is because you didn't listen to what I said yesterday, and you didn't use the defects as a guide. There was all this pointing up at the sky here, here, right? Like here, okay, all right, but and okay here and okay here, but still up here, you should have rotated that to 6 o'clock, and you should have gone along with the catheter in the defect. But I know stress of the score, whatever. Yeah, however, well, maybe you should have said that, but this is really directed at Xander for his technique, because Xander wants to be the best of the best. I know that, and therefore won't mind me saying things which will make him the best of the best, like John Anderson.
So I think you did a very good job at doing what I said. You're capable of executing everything perfectly, very meticulously. So I think that is the best kind of trainee you can have, one that can listen and do what you, because you said you can only do one thing at a time. I think you're underestimating yourself. You listened and did it. So that's two things. Then that's about the defect. I think David said this already, that you do the margin ablation. Where does it start here? And I think I was maybe not clear myself, but what I wanted to, and you did it here for the front part, have it at the 6 o'clock, and I should have told you then to turn it around, so to have the back part again at 6 o'clock. But I already felt almost your heart rate go up when I took out my phone, so I'm very sorry for that. We all know that you're very good at these things. And then the clipping, the last part, I think, or maybe we can quickly skip to that. I think the first clip, you know yourself, was not the best clip, but I was here myself demonstrating I'm not a proper woman. I was, and you're talking to the camera and not looking at your clip. So what you did here, thinking back, is that you just actually took the mucosal margins, and there was no. Why is it difficult to get this in? It's actually not even very clear. It's here, so we don't even really see what happened here. Yeah, right. So I filled this in up front already. So we had an SMSA 3 and no plus, so no very big polyp. It was granular, lifted very well, and was not in a very difficult position or in a special position. Okay, well done, Sonia.
Thank you. Then go sit there. So John,
yeah, okay. So Lynn, that was a very different experience to the first time. Yeah.
Yeah, definitely.
Yeah. So why do you think it was different?
But first of all, the trainee, obviously, the trainee is sorry, is somebody I work with every day, and I know what I can expect from Sander, from really. I see him work doing polypectomy every day. That's one thing. So I feel so very comfortable standing next to him. I know what to expect, and I think that the polyp, or this part, was not a resection, but I know very well here what to do, and I know Sander will be able to execute it. Whereas the first time, it was a bit of a surprise how it would go, and it was from the first minute clear that was going to be very difficult. And it's just way easier to explain something to somebody that you, with one word, already know he will understand. So the amount of me. Of thinking and being conscious about what I was doing was much lower than the first case. I just had to. It was more working together here than really being his trainer at some point. So that is I think the most important difference.
And it's not black and white. So you got to understand where he's coming from, because when you're then having the debrief with him, if I say to Sander, tell me one thing Lynn said to you, he'll not remember anything you said to him because he wasn't thinking about it, right? He could only think soft tip coagulation. Is that true, Sander?
Yeah.
So as a trainer, it's really difficult. So you have different roles and you have to understand where you're coming from and what the trainee really wants. But for me, for that, I thought that was a great demonstration on lots of levels. So firstly, the polypectomy was very good. I thought the defect assessment was very good. I thought the clipping was very good. And then it gave David and I a platform to have a chat about some of the refinements of technique. But for you as a trainer, which is really what it's all about, Lynn, you need to take all the good stuff you've got and push that really hard. Recognize where I need to practice something. And I think I agree, I include myself in this, we need to be able to take people who have got a lesser skill set than ourselves and be absolutely clear to make the room comfortable, to make the training comfortable, and ultimately to have a successful outcome. And that requires a lot of hard work. And I think the better you're prepared to do this in terms of your educational contract and putting in ground rules and knowing when to step in and know when to speak and when to be quiet and what language to use, the more we get familiar with doing all of that, the easier it will become.